look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
Hi everyone, I'm Charlotte. Similar, I don't know if I'm still qualified to say I'm a young person or living with cardiomyopathy, because I'm actually a transplantee, so I no longer have cardiomyopathy technically, but still feel part of the club and have kind of experienced pre-cardiomyopathy, cardiomyopathy and post-cardiomyopathy, so a bit of a strange journey and perspective, I suppose, on things. I'm interested to know who is a patient and who is a parent, if I could just see hands if you're a parent. And if you're a patient? Okay, cool. Just interesting to know, I guess, what people want to hear about. But I think if you were at the start of today and heard the story of diagnosis, I don't think it's unusual that it takes a long time to be diagnosed. So a little bit about me, was perfectly healthy up until about 18, 19 years of age. I was in my first year of university, living in the city of Liverpool on my own, thought I was a grown-up at the time, and figured out that walking to lectures was slightly different for me than it was for everybody else. I was walking up, I don't know if anyone knows Liverpool, but up quite a large hill to get to my lectures, and very much put myself off making friends and walking with people because I was significantly slower than the rest of the people that were walking. It started to become quite painful to walk as well, which it's quite an alarming feeling, but also a bit embarrassing to kind of explain to people, this is painful actually for me to walk and I'm very out of breath. So I went to see my GP in Liverpool, who told me I was probably anxious about my studies and that was why I was so tired. Went to see a GP again when I went home for the summer and was given antibiotics for a chest infection, which I definitely didn't have, but you kind of just go with it and take the advice of your doctors. And then eventually my mum told me about a charity screening. I don't know if anyone's heard of CRY or cardiac risk in the young. A lady in our local community was running one after losing her son, and I kind of went along with my now husband. We cycled there because I couldn't drive at the time. That was my mode of transport, unfortunately. Had an ECG, which was definitely abnormal, and went for an echocardiogram, which at the time I'd never heard of, didn't know what it was, and disappeared essentially for half an hour to go and have that done. I was then referred to a cardiologist. It was a very blasé approach at the screening. It was kind of, there's something wrong, but we don't really know what it is, can't really tell you. We're going to refer you for some more tests. And similar to the talk we heard at the start, was very much a relief for me. It was, okay, I'm not anxious, I've not been making these symptoms up. I'm hopefully going to recover from this, and it's not that I'm just going to have to live my life differently to everybody else. Went privately, because it was 3 months then to go and see a cardiologist, and we'd been on holiday in Barcelona where I was taking multiple naps a day to get through my day on holiday, which was starting to get slightly worrying. So I went to see a cardiologist under Liverpool Heart and Chest, Dr. Todd, who was amazing, and very much anyone that was in the session around shared decision making cared about what was important to me. I wanted to be healthy and to be able to live my life, and that was more important than potentially going on a really high dose of beta blockers that would help my, medical symptoms, but actually I couldn't get out of bed because I was so tired and just exhausted from the medication. Fast forward less than a year, and it was very much apparent, we think you have restrictive cardiomyopathy. We're not 100% sure because I carry the gene for hypertrophic cardiomyopathy, and even to this day, they're not 100% sure what I had, but was very breathless, very tired, and had a lot of fluid as well, which didn't help. So they kind of said the only cure, I suppose, for this is that you'll eventually need a transplant, which at the time I was 18, 19, and thought maybe I'll get to like 45 and then, decide that that's the best course of treatment for me. But I think in my probably second year of uni, I wasn't going out to the shops. I was struggling to actually look after myself, just purely down to tiredness and being able to get out and about. And they were things that came up in my doctor's appointment. So it was, how are you feeling? Like, be honest. I was always, yeah, everything's fine. It's all good. I'm managing. And yeah, it kind of came about that wasn't the case. And I was referred to Withenshaw's transplant clinic. And I went for my assessment in December 2017. So only about a year after I was diagnosed. Was put on the transplant list February 2018, and 3 weeks later had a whole new heart and was no longer a cardiomyopathy patient. I was a transplant patient, which you basically swap out a load of drugs and get a whole new bag of drugs, and they do all weird different things than they used to do. But fully got my life back. I was a completely different person than I was pre-transplant. I have a huge amount of admiration for people who live with cardiomyopathy. I didn't have to live with it for very long. It was kind of a year where I went downhill very quickly and never had to kind of navigate going back to school, going back to work. They were all just things I stopped and knew that eventually I'd be able to do them again. So I always come to these and I'm fascinated by how people manage their symptoms and are able to get on with their lives. I think something that has come about probably later on, quite recently, is that it was a very fast journey. I didn't really process being ill or being really ill or then being better again. And I kind of just get on with my life, and occasionally things set me back where I realise I haven't processed a lot of what actually happened to me and probably respond to things in a very different way than I would have done had I have not had cardiomyopathy or had a transplant. But I'm a big advocate for talk to your doctors and tell them what is important to you and what you like to do with your life. It's not just, yep, give me all the drugs if they're going to make my life last longer. I think it's important that you can still do what you enjoy doing. And I still very much enjoy speaking to cardiomyopathy patients and helping people to realise that, I suppose. And then moving forward, really, so I'm coming up to 6 years post-transplant in February. Is that? Yeah, it's not, I can call it nearly 6 years. I have no health conditions. Aside from that, I don't have any post-transplant issues. Been incredibly lucky in that respect and have just gone back to my normal 27-year-old life. And I can't really complain. Moving forward, there is a genetic aspect of my cardiomyopathy. So in terms of family planning and things like that, we now know that that's something I carry, and there are options that are available, which when I was 19, it was just don't have a baby. Please don't do that because your heart can't cope with it. And there are now options of how to safely do that or choose just to not pass that gene on, which is why I still come to these things and learn about all the new things that are happening. I'm also a telephone peer support. So if anyone wants to speak to someone who has been every side of the spectrum of cardiomyopathy, that's something that I very much enjoy doing. That's me. I will hand you over to the man who knows a lot more than I do. Thanks, everyone.
Thank you very much, Charlotte. And actually, I don't know that I know much more than you. In fact, I'm sure that I don't know more than you. And actually, I think that's a really important point, because we look after patients who have cardiomyopathies, but actually the people who know the most about their condition is you guys, people who actually experience it. And it's always really powerful to hear your story, but also I think just reflecting on the fact that everybody with a cardiomyopathy has a different experience. And actually being able to put all of that together, when we look after patients, for us is really, really important. So my name's Juan Pablo Kaski. I'm a professor of Paediatric Inherited Cardiology at Great Ormond Street Hospital. And I specialize in looking after children and adolescents with cardiomyopathies. And what I would like to do today, and I'm going to try and keep it as brief as I can, just because I know that often the most important thing and the most useful thing for all of us is the opportunity to sort of ask questions and answer questions, and so hopefully there'll be enough time for that. What I'd like to do is just give you a really brief overview from a medical point of view of what we understand about cardiomyopathies, and also just some insight into what's new in the field. And I think this is a really relevant time. I don't know if you guys are aware, but in August this year, the first international guidelines ever to be published for the management of patients with cardiomyopathies came out. So up until now, we only had guidelines for hypertrophic cardiomyopathy that are produced by international societies, and they're meant to guide clinicians who look after patients with cardiomyopathies. But we only had those for hypertrophic cardiomyopathy, and this is the first time that we have a set of guidelines that covers the whole range of cardiomyopathies. And I was really, really honored to chair this document with my colleague Elena Rebelo from Barcelona. And we're now working on a patient version of these guidelines, so something that we can give to families and to carers that sort of summarizes the impact of this for an individual patient. The other thing that's really unique about these guidelines is that whereas most guidelines produced for most cardiac conditions are really for adults, and occasionally there'll be like a little sentence or paragraph about children and teenagers, we were really, really keen that these guidelines reflected what we know about cardiomyopathies across the lifespan. And we know that these are conditions that can present at any age and that can affect lots of different people in the family. And so one of the things we were really keen to highlight is that the recommendations that we produced here don't just apply to adults, but they also apply to children. And there are, of course, differences. And where those differences are present, we were very keen to highlight those differences. So most of the recommendations here relate to children and adults, but there are some that are specific to adults and some that are specific to children and teenagers. So I know that most of you here are cardiomyopathy patients, have a cardiomyopathy. I don't know how many of you have been living with cardiomyopathy for a very long time and how many have only very recently been diagnosed. So I thought I'd just start from the very basic, the very beginning of this. And because cardiomyopathy is a very long word, but actually, like most things in medicine, we use very long words to describe quite simple things. So cardiomyopathy just means disease of the muscle, of the heart muscle. Cardio means heart. Myopathy means disease of the muscle. So cardiomyopathies are conditions that affect the muscle of the heart. And there's this definition which, when we make the diagnosis, we need to rule out other conditions that can cause the heart to look similar to how it looks in a cardiomyopathy. So there are other, for example, having a very high blood pressure can give you thickening of the heart muscle. That's one of the things that we need to rule out in somebody who might have hypertrophic cardiomyopathy, for instance. But essentially, we're talking about diseases that affect the muscle of the heart. And the way that we make the diagnosis, or the way that we describe the cardiomyopathy really is based on how the heart looks. So when we do the tests, we look at the heart, and that's what determines the first step of what we call the cardiomyopathy. So we look at things like thickness of the heart muscle, that's hypertrophy. We look at things like enlargement of the heart muscle, dilatation. We look at the pumping function of the heart, that's systolic function. We look at the relaxing function of the heart, we call that diastolic function. And for the first time in these guidelines, so up until now that's what we generally use to describe cardiomyopathies, but now for the first time we are also including some of the things that we find on MRI scans of the heart. So the MRI scan allows us to look at the tissue, the heart muscle tissue itself, and in particular, it allows us to see if there's any areas of scar tissue that are replacing healthy heart muscle. And so when we use these things, these traits, we call them, when we look at the heart, this allows us to divide the cardiomyopathies into actually now 5 different groups. So there's hypertrophic cardiomyopathy, which is a thick heart muscle. There's dilated cardiomyopathy, which is an enlarged heart muscle, which sometimes doesn't pump quite so well. So enlarged, the heart is enlarged, but the muscle itself often is thinner than usual. There's didn't mean to do that. There's arrhythmogenic right ventricular cardiomyopathy, which is a very specific form of heart muscle condition that affects the right side of the heart and can give you extra beats and abnormal rhythms. That's what arrhythmogenic stands for. There's restrictive cardiomyopathy that Charlotte's told us about already, where the heart actually isn't particularly thick or particularly enlarged, but it's stiffer than it should be. And that's what restrictive means. And then there's this new sort of criteria or classification or a description, really, that we call non-dilated left ventricular cardiomyopathy. And I think Perry Elliott this morning sort of showed some examples of this. But this is what we can diagnose by looking at scar tissue on the cardiac MRI. So where we know there's a heart muscle problem, but the heart's not enlarged, it's not thick, but what we see is scar tissue. And this is a condition that's important to pick up, and I'll show you why later on, but because when we see this, it makes us think of very specific genetic defects that are really important to pick up, because if we know that they're there, the way that we manage that condition from a medical point of view will be slightly different. In terms of how common cardiomyopathies are, we know that they are much more common in adults than in children. And the types of cardiomyopathy that are more common in adults and in children are slightly different. So in adults, hypertrophic cardiomyopathy is probably the most common type of cardiomyopathy. So that happens in at least 1 in every 500 people. Whereas in children, hypertrophic cardiomyopathy is about 10 times less common than it is in adults. And the most common type of cardiomyopathy we see in children presenting in childhood is dilated cardiomyopathy. So there are some differences in how these cardiomyopathies present. This is a figure from the guideline that is basically trying to show what we do when we see a patient or a person who we suspect might have a cardiomyopathy. And the way that, and it's meant to go through sort of the patient pathway. So from the point at which they present to the point at which we're making a diagnosis. And then there's a second half of this diagram that sort of tells us what we do in terms of treating that. And a little bit like sort of Charlotte described earlier on, the way that people with a cardiomyopathy present can be really non-specific. So often they might present because they have symptoms, but actually those symptoms aren't necessarily symptoms that the GP looking at them will think this is definitely a cardiomyopathy. We should definitely focus on that. Sometimes there'll be really non-specific symptoms. And so as Charlotte says, sometimes it does take a little bit of time to reach the diagnosis. But one of the things that we were really keen to do here, because that sort of time is not just at the GP, even when you see a cardiologist, they may also not be thinking about a cardiomyopathy to begin with. And so one of the things that I think is really important is that we empower cardiologists to think about the possibility of a cardiomyopathy when they come across a patient who has symptoms like chest pain or breathlessness or palpitations, or when they have an abnormal ECG, for example, or certainly when they present with a family history. People should be thinking about, could this be a cardiomyopathy? And once you start thinking about things in that way, then it becomes much more easy to reach an actual diagnosis. So we start off from the way the person presents. We look at the heart, so as I described before, by looking at the size and the function of the heart. We then sort of describe where within those boxes that particular cardiomyopathy might fit. And in the past, that's where people would have stopped. And you'd have said, okay, you've got hypertrophic cardiomyopathy, you've got dilated cardiomyopathy, and that's your diagnosis. But actually, that's not the case at all. This is the beginning of the diagnosis. So hypertrophic cardiomyopathy is not a diagnosis. It's the start of the diagnostic process. And what we then have to do is to look for other signs, other clues in the family history, on the ECG, on genetic testing, for example, that allow us to reach a much more specific diagnosis, which in many cases will be a genetic diagnosis. In children, this is particularly important because certainly in children who present with a cardiomyopathy in the first year of life, there are very specific, rare causes that we need to rule out because they have a very different natural history and they have very different treatment options available to them as well. So we look for lots of different red flags to try and rule in or rule out specific diagnoses. But these are super, super rare. And actually most of the time, even in children, the things that cause cardiomyopathy are exactly the same as the things that cause cardiomyopathies in adults. there are a number of common features to how we manage cardiomyopathies, again, across all age ranges, so children and adults. So we know that some of them, most of them, are genetic, but some are not genetic, and so we have to think about non-genetic causes. We know that they can be very different, even within the same family. Different people with a cardiomyopathy will express that cardiomyopathy in different ways. And part of that is, again, really long words that we use in medicine, but this thing called age-related penetrance. And basically what that means is that the gene, whatever that gene is that's causing the cardiomyopathy in the family, will express differently in different people in the family, and part of that difference in expression is related to growing up. So some of the features might not be there when you're a child, and they might start to develop as you get a little bit older. And that's part of the reason why cardiomyopathies are less common in children than they are in adults, because although the gene is there, it may not be expressing itself fully in childhood. And in terms of management and treatment, there are a few things that we always have to think about. So we have to think about looking for a genetic cause, and we have to think about screening the family. We have to think about managing symptoms. So if somebody has symptoms, working out why those symptoms are happening and then treating that. And that's often with medication, but not always. There are other things that we can do. And then also about preventing some of the complications that might arise as a result of the cardiomyopathy. And that's sort of what I want to just sort of talk about over the next few minutes. So in terms of the causes of cardiomyopathy, I've sort of alluded to this before, so I'm not going to spend too long in this, but there are lots of different things that we have to rule out. And in particular in children, there are these long lists of really rare conditions that often don't just affect the heart, but also affect other parts of the body as well. So it can affect your sort of skeletal muscles, they can affect your eyes, your kidneys, etc. So ruling these conditions out is one of the first things that we have to do when we see a child with a cardiomyopathy. But as I said before, most of the things that cause cardiomyopathies in children are exactly the same genes that cause cardiomyopathies in adults. And it might seem that this is sort of quite obvious now, but actually until about 5 or 6 years ago, that wasn't the case at all. Most cardiologists used to think that cardiomyopathies in children were completely different to adults. They used to think that they were always caused by these really, really rare conditions. And actually, we know that that's not the case. So the causes are exactly the same. Generally, they're genetic, and they're inherited in what we call a dominant way. And what that basically means is that if somebody has one of the genes or one of the faulty or a spelling mistake in one of the genes that causes a cardiomyopathy, there's a 50% chance or a 1 in 2 chance of passing that on to each of their children. Having the gene doesn't necessarily mean that you will develop the features of the condition. So some people can just carry the gene, some people can have very mild features of the condition, but it's a 50% chance, a 1 in 2 chance of passing the gene. And if you know what the gene is, then you can test for it. And this is the first bit. This is sort of screening. So when we talk about screening, there are 2 bits of screening. So this is when we know that somebody in the family has a cardiomyopathy, and we want to look at other relatives in the family to see whether they have also inherited the condition or not. And there are 2 bits to that. There's clinical screening, so ECGs and echoes, looking at the heart itself, and there's genetic screening. And this is a really complicated algorithm from the guideline, but essentially what it says is that if you've got a cardiomyopathy, you should do a genetic test to look for the cause. If you find a spelling mistake in a gene that you're happy explains the condition in that person or in the family, then you can offer genetic testing to all the relatives. We call them first-degree relatives, so that's parents, siblings, children. And if they don't have signs of the condition and don't have the gene, they can be discharged. So they don't have to keep coming back. But if we do the genetic test and we find that the relative carries the gene, that doesn't mean they have the condition. It doesn't mean that they will definitely develop the condition, but it means that we need to continue to monitor things and keep an eye, because there's a possibility that the features of the condition will develop over time. And I'm going to rush through this, but just to say that, again, until really very recently, the general recommendations were that we shouldn't be offering screening, either clinical or genetic, to children under the age of 10 or 12, because there was this idea that genes didn't express themselves in younger children, and so there was no reason to offer testing. And previous guidelines for hypertrophic cardiomyopathy in particular also said that. Don't think about screening in younger children. Over the last few years, we've shown that that's not the case at all, that actually once you start looking, I'm not going to go through this in detail, but once you start looking, there is evidence that the genes are expressing themselves, even in younger children. And so we've changed the way that our recommendations in the new guidelines to highlight that. So this is related. So one of the reasons that there are many reasons why the recommendations suggested we shouldn't be testing younger children, but one of them was that there was a worry that we might be causing more harm by screening and offering testing, that we might be causing psychological harm. But no one had really looked at that, and it was quite a paternalistic approach to say, well, we shouldn't test because we don't want to worry these children who might end up carrying the gene. And when we started looking at it, and most importantly, when you ask patients themselves, teenagers themselves, do you want to know your genetic results and when do you want to know it? They do want to know. And we've shown that actually with the right approach, there's no evidence of increased anxiety or causing psychological problems in younger children. And so and this is not just hypertrophic cardiomyopathy, but all the cardiomyopathies. And so the new recommendations now also include a specific recommendation that genetic testing should also be performed or should be offered in younger children as well. So that age cutoff has disappeared. Part of that process is not just ordering a blood test, but there's a whole process of genetic counselling. And so there are lots and lots of things to take into account when you're speaking to a child and to their family. The important thing is to offer the testing. Some families may choose not to go ahead with it, and that's absolutely fine. Other families might choose that they want to do it, and that's also absolutely fine. But it's thinking about all of the implications of that. One of the things that we always think about when we look after patients who have a cardiomyopathy, particularly children, is the risk of complications. And for most people with cardiomyopathy in childhood, that risk is relatively low. But some people with cardiomyopathies do have a slightly higher risk of things like abnormal heart rhythms and sudden death. And that's one of the things that we always have to think about when we treat cardiomyopathies. And again, this is something that we are addressing in the guidelines. And in particular, there's this concept, I think Professor Carr-White did a session on shared decision-making, and I think this is particularly relevant when we talk about risk, and particularly relevant when we talk about risk in children with cardiomyopathies. So in individuals that we think have a higher risk of abnormal heart rhythms, there's the option of using a defibrillator, an ICD, as a way of preventing dangerous events. And that decision to implant an ICD is something that has to be taken in conjunction with the child and the family. So again, it's not a decision that we say, look, we think your risk is high, therefore you must have an ICD. There are lots and lots of things to take into account. And we, in the guideline, very specifically talk about this concept of shared decision-making. That isn't just what us as the clinicians think, it's also what's the impact of what we're talking about on the particular individual and on that family, and also us being honest with our patients and saying that we don't understand all of the things that are associated with this. We don't understand all the risks. Even when we assess for risk, we're not perfect at working out who has a high risk and who has a low risk. And so taking all those things into account in that conversation is really, really important. And we now, for many of the cardiomyopathies, have tools that allow us to make a much more personalized assessment of risk. So in the past, we used to say, right, you've got 2 of these risk factors that we think are risk factors, therefore you should have an ICD. Now we incorporate lots of information that we get from the tests that we do, and that sort of feeds into an estimate of what the risk might be for that particular individual. So we're beginning to use much more personalized tools for that. And that's sort of highlighted in the guidelines. And specifically for children, there are now really good tools to assess risk of abnormal heart rhythms in children with hypertrophic cardiomyopathy. And that's now also incorporated into the guideline. For other cardiomyopathies, 2 of the most important things that we take into account when we think about risk is the presence of scar on MRI, and most importantly, probably the genetics. So when I sort of talked before about certain genes being important to pick up, it's because we know that if you have changes in certain genes and you have a dilated cardiomyopathy or a non-dilated cardiomyopathy, your risk of abnormal heart rhythms is significantly higher. And so whereas in the past, we would have just looked at the pumping function of the heart to determine whether somebody should have an ICD or not, Now we're able to use genetics to give us a much better idea of what that risk is. And so knowing about the genetics is important, not just for family screening, but also in terms of management. And these are just some examples of those genes that we're talking about. And then finally, in terms of treatment, one thing I'd like to highlight is how important multidisciplinary approach is. So when we're treating families with hypertrophic or with all the cardiomyopathies, first of all, we're treating the whole family, so not just the patient. But also, it's not just the cardiologist or the paediatric cardiologist that's important in that context. There are loads of other specialists and non-specialists, including patients and patient societies like Cardiomyopathy UK, that are really important in terms of delivering that care. And also, not everybody with a cardiomyopathy can be looked after in a specialist centre across the world. And so really good communication between specialist centres and more local hospitals is really important. These are the sort of general things that we think about when we treat cardiomyopathy. So if there are symptoms there, we work out why they're happening and we treat them. We try to prevent complications, family screening, and we've already heard from Charlotte how important issues around lifestyle are as well. Symptoms in children can sometimes be quite difficult to pick up. So that's sort of a list of the things that we would normally look for, but actually a very young child really won't be able to tell you whether they're having chest pain or getting palpitations. And so we need to look for other clues when we think about possible cardiomyopathies in some of these children. And then in terms of the tests that we do, I wasn't sure who would be in the audience, but I guess you've all had all these tests, so I'll really sort of whiz through them. But the ECG is a really important first test. The echo scan is probably the gold standard in terms of making a diagnosis, because it allows us to look at the size of the heart and the pumping function of the heart. It allows us to look at all of the aspects that allow us to make a diagnosis, apart from that scar tissue, and this is where MRI comes in. So with MRI, we can look at the same things that we get on echo, but we also get an assessment of whether there's scar tissue, and those sort of pretty pictures are ways of looking at the amount of scar tissue within the heart muscle. We do other tests as well, so things like exercise tests, 24-hour tapes, and then we've sort of touched a little bit on lifestyle issues, which I'm not going to go into too much detail now, but hopefully if there's time for questions, we can sort of go through those. Exercise is one of the things that people always ask us about in relation to lifestyle. And again, there's been a bit of a shift in the past. People might have been recommended to avoid all exercise just because they have a diagnosis of cardiomyopathy, and that's now changing. So actually, in the guidelines, we have recommended that regular to moderate intensity exercise, so not competitive, but that anybody with a cardiomyopathy who's able to do it should actually stay active and stay fit and stay healthy. So actually exercise is positive, it's beneficial. And then you need to think about individual things. So particular genes might be associated with a slightly higher risk. Particular types of cardiomyopathy might be associated with a slightly higher risk. So there are differences within the different cardiomyopathies, but the basic premise is that exercise is a good thing, and so there shouldn't be a blanket ban on exercise, and that's really important in children in particular. And there are some psychological recommendations in the guidelines as well. And then just the last slide, all the treatments that we have talked about, things like symptoms and preventing complications, none of those deal with the underlying disease process, but we're now beginning to have new treatments developed that really target the underlying problem of the heart muscle. So in hypertrophic cardiomyopathy, you might have heard about mavacamten, which is a drug that treats outflow tract obstruction. It's the first drug ever designed for hypertrophic cardiomyopathy. And there will be clinical trials in children and teenagers coming up in the next year. For some of the really rare conditions that I talked about right at the very beginning, we already have cures. So enzyme replacement therapy can get rid of the wall thickness in some of these very rare metabolic conditions. But most people don't have these conditions. Most people have a common cause of cardiomyopathy. But these new drugs are coming onto the market, already in the market for adults, and will hopefully be in the market in children very soon as well. And there are also gene therapy trials that are already enrolling. So there are 2 particular gene therapy trials that have already enrolled adults with cardiomyopathy. So I think the future here is really, really bright. There are lots of new treatments coming on, many of which are probably going to be even more effective in children and teenagers than they are in adults, because we're potentially capturing an earlier phase of the disease. But anyway, I'm going to stop there. I don't know, Emma, were you going to sort of say a few words? So maybe we can sort of leave questions till afterwards, but thank you very much.
Oh, sorry, there it is. Is that it? So as Professor Kaski said, I'm Emma. I'm one of the nurse specialists from Cardiomyopathy UK. I'm a paediatric nurse, inherited cardiac conditions by background. And so this should tie nicely from Dr. Kaski's talk about how we can support the family. So as Dr. Kaski, Professor Kaski touched on, is that diagnosis can be quite difficult in children. It's not always as black and white or a simple road. It may have been a long process. It may have been sudden and scary, particularly if they're a young baby. And also, it's quite an adjustment trying to understand if your child has been diagnosed with a cardiomyopathy. We know parents, after speaking to parents for many years at the charity, is that the main sort of messages that people are wanting to know is they want to feel heard, they want to feel understood with their child who has a cardiomyopathy. And, you know, lots of different, you know, areas that we talk about with parents. We talk about, you know, resources, we talk about recovery from the diagnosis, we talk about support systems in place, and feeling in control and feeling a bit more informed about the condition and your parental role. And I think a lot of the take-home messages today from most of the conference today is about patient empowerment. And I think as a parent, and Professor Kaski also spoke about the joint decisions and care for our children with cardiomyopathies, that you know, it's about sort of learning about your child's cardiomyopathy, learning about your child's worrying symptoms, and keeping up to date, you know, with what's going on in the cardiomyopathy world. One of the big things is having a child is getting the right sort of care once they get back home into the system, and that's having an individual care plan. So this is something that the nurse specialists at your specialist centre, or perhaps your community nurses or school nurses, they will work with your cardiologist and the nurse specialist about developing this healthcare plan for your child with cardiomyopathy. It's not to be confused with an educational healthcare plan, but it's a specific care plan that's designed for your child once they get home and get into the community and try and get back into school, into some kind of you know, nursery environment, to make sure that your child receives the best care when they're away from you, the parent, and that their cardiomyopathy is understood and that they're safe, basically. So what should that care plan really include? It should have a detail about what cardiomyopathy is, and I think Dr. Kaski summarised that beautifully about what the cardiomyopathy is. So just make it nice and simple for your child's teachers or nursery workers about what the cardiomyopathy is and what that actually means for them at the nursery or the school. What should they be looking for? What are the worrying signs and symptoms? And then what to do when they see any of these worrying signs and symptoms. And also on that care plan, it should have a detail about medications, what sort of medications the child's receiving most of the time, and hopefully those medications will be given at home, but if there is a lunchtime dose to be given, make sure that that care provider understands what the medication is, what it does, and how it's to be given, and that there should be a separate medication form for that as well. And I think it's really important, part of that care plan, that there is a plan for an emergency plan. So there'll always be people within your school or nursery that have all got first aid training, but just so that they know as well what to do with your child specifically if something was to happen, like a sudden cardiac episode. And within that care plan also has all the contacts on there, so that if you do have any questions around the child's cardiomyopathy, or you're not quite clear about a new child that's starting, you can reach out to these nurse specialists at your specialist centre or your local cardiac team. So, you can perhaps have a team, a visit, a school nurse visit to come and visit the establishment, and they can talk through the child's cardiomyopathy and generally make the school or the nursery feel a little bit more confident in managing your child with a cardiomyopathy, because it can be quite scary for them. This is just a really basic sort of form of what it looks like, but every different school or it will have their own sort of templates, but it's just to sort of make sure that it's all outlined quite clearly and it's there as a grab sheet so that, different care workers can have access to that. So where does Cardiomyopathy UK come into all of this? So as a charity, we're basically there to help families and parents feel informed and confident around the child's cardiomyopathy, to feel in control about the cardiomyopathy, and that you've got those coping mechanisms, that you're going to feel that you can, get through this and that you're supported. And it's a really lovely feel of a community as well, so you can reach out with other families, other parents that maybe have children with cardiomyopathies. So how can we support you? We've got our helpline, we've got the nurse helpline, which is Monday to Friday. We also have an out-of-hours helpline specifically for parents and carers. That's every second Wednesday. I'll talk a bit more about that in a second. We've also got email that you can just email, quick-fire emails, like you might be at work or you might be at home really late at night and you haven't been able to get through to your normal nurse specialist team or your community nurses. You need to discuss something through, we can always make a call back the next day. We can't advise or change any kind of medication plans, but we can always advise and help point you into the right direction. We have live chats on the website as well, which is another fantastic quick service. So I'm one of the nurse for paediatric nurses. I'm only there one day a week doing the paediatric helpline, but also the out-of-hours helpline. So extra support for parents and caregivers, what we have through the website, we have actually a closed Facebook group. I don't know if anybody does Facebook, but that's specifically for parents. So that's a really good sounding board for various parents if they want to connect with other parents. And it's also monitored by the nurses. So if you wanted to, ask any questions or, but again, it's more sort of a sort of there as extra support. We've got lots and lots of information that the nurses provide for families and parents living with children with cardiomyopathies. We've just piloted a Thriving with Your Child's Cardiomyopathy. It's been a 4-week course. We're coming up to the last one next week. Each week we've covered different topics that are relevant to parents that are navigating, looking after a child with a chronic condition. And that's alongside a psychologist, Willow, who also has a child with cardiomyopathy. We also have various webinars that we host as well, and they're really informative for parents to help, help make things a little easier with your child. So much information on the website. We've also got various little packs for children that they can also have a look through that are appropriate to various age groups. And a lot of the specialist hospitals will have these activities packs as well. We've also got YouTube videos, which a lot of these videos today will be uploaded onto the website. So if you haven't been able to go into the other talks and you'd like to access them, they'll all be there. But specifically, there is stuff for children to access as well. We've got a quick sort of bite-sized video for children to access that they may want to understand a bit more about their cardiomyopathy, and children love to be in front of a screen these days. We've got lots of resources for fact sheets as well that you can download, and you could give to your schools and nurseries as well to help them understand the cardiomyopathy. When it comes to teenagers and young people, we've also got a whole separate youth hub that we're trying to get up and running. It's a tricky demographic to kind of get to engage with, but we're really trying to, push that kind of side of things. We really want our young people, because we know they're very much, into accessing things online. They're not as open to attending support groups and calling up nurses, but we think that, they really can benefit from information online. And at the end of the day, if you are, around teenagers or raising teenagers, you've got to get through a lot of noise. You've got children that are able to just, at the click of a finger, click of a button, access so many things, and some of it can be, I don't know if you've had a look, but it can be quite petrifying. So on our website, there's a lot of, really good, quick, bite-sized information for young people and teenagers to access that it's appropriate for them as they navigate through various parts of their life, going to university, starting at a new job, lots of up-to-date exercise, active advice as well. We also have a youth panel, which, again, it's tough crowd. We're trying to get lots more youth panel people that can help us engage with the younger people. So if you're ever interested in wanting to try and help us raise awareness for young people with cardiomyopathies or help influence the service that we provide for young people, we'd absolutely love for you to reach out. We have an Instagram page as well for young people. Again, this is just specifically for young people, and we have takeovers by the young people that have cardiomyopathies. They're the ones that are pretty much guiding us through this crazy social media time of life. So if you know any young people, please do point them in the direction of our Instagram page. And that's us in a nutshell. Thank you.
Could I ask Charlotte and Emma to come up with one and answer any questions? I'll bring the microphone round if you indicate you've got a question. So anyone want to start off?
My son is 15 years old and has dilated cardiomyopathy. How does it work with the transition to adult services?
Yeah, I mean, it's a huge part of a teenager's journey. It starts sort of from a sort of early teenage age, around 13, 14. They'll start to talk about it in your clinics, along with, your cardiologists. And it will be, again, a nice shared family decision when that child's ready to transition. They're not just booted out as soon as they turn 18. It's about working with the family and finding, that right, clinician that might be right for that child if they're moving perhaps away for university. There's all sorts of discussions around that, and it's very much a pathway that all clinicians are very much experienced in working with.
Yeah, I guess it depends also a little bit on the individual sort of centre and where you're followed up. So some centres will have slightly different pathways for transition. Can I ask you guys a question? So looking after lots and lots of families that we do, it seems to me that there's a time period that isn't very well catered for in terms of medical care and clinical care, when lots of other things are happening. So I think the early paediatric age group, I think, is often very well looked after. Adults with cardiomyopathy are very, very well looked after. But I personally feel that there's sort of a group of people between sort of 14 and 25 maybe, where actually the healthcare system isn't really set up for that group, and we end up transitioning at sort of 18 years old, at the same time that you might be leaving school or starting a job or whatever, having started getting a boyfriend or a girlfriend, or with lots and lots, learning how to drive. Lots and lots of things are happening at the time, and I guess my question is, if there was a specific service for people between the age of 14 and 25, is that something you guys would access, would like to do, or actually is it better just to stay with your paediatric team until you're 18 and then move to an adult hospital when you're 18?
I was diagnosed when I was 1.5, and I'm now 21. So I've been through the paediatric, the transition clinic, and I'm now in the adult clinic. Yeah, I would definitely say that, although obviously the nurses try their best and they do educate you about things, going through teenage years and things, I do find that I don't know anybody my age who has cardiomyopathy, and although it's a great thing that all of these things are now accessible online, I find that because it's online, it's harder to find other people who have been through similar experiences as me, because it is different living as a young person with cardiomyopathy than an adult, and it was also nice to know people who were diagnosed at different levels, because I was obviously diagnosed so young. I know a lot about my condition, but it's still nice to have that support there from other young people, not just the medical professionals. I definitely think that would be useful.
could I add, is there anything more you think the charity should be doing, or where we should be putting more effort in involving more of this sort of younger adult age group?
In terms of the youth hub that we have, it's in its infancy, so we're definitely developing it more, and there's going to be lots more coming. We've just appointed a new youth manager over there, Cam, so he's going to be, getting that up and running hopefully in the next. But it's a tricky audience.
Yep. I mean, we have been through one iteration, which ended about 2 or 3 years ago, ended during COVID, really. But we were in a position where we did have a youth panel that was reasonably active, and indeed the chair of the youth panel became one of our trustees, so actually sat on the board of the charity, because we felt it was that important that we listened to that voice. But then, for whatever reasons, probably something to do with people going off to university, starting careers, the chair of the youth panel, got a promotion, and suddenly, at age 26, was into his full-time work, and that rather fell apart. And so we really want to get that resurrected, as Emma says, and that's is going to help us do that. But we need your help as well. And if you're keen to be part of that, we need to know. So, any sort of questions or comments or things you'd like to put across?
Bit close. I was diagnosed with DCM a year ago, and there's been a real strong link with men in our side of the family that have all died real young of heart problems. So we've gone through the genetic testing, and they're still unable to find this link. So I've had a little boy who's now 5 months old, and he's gone in to have, I think it was an ECG and a echocardiogram. And they've said that there's no, because there's no genetic link so far, he's not necessarily in the inherited heart clinic as such. And because this scan that he's had has shown no issues, all we got was, we'll see him in a few years' time. But obviously what you were saying there is that we sort of felt that there's still this sort of old attitude of being like, well, and what they said to us was, well, if there is a problem, it won't show when they're kids anyway, it will be when they're in their teens when it's going to develop. But obviously listening today, it's not necessarily the case, is it? It can show. So I just wondered what the sort of journey looks like for him being in the system. Is he going to be regularly monitored, or do we need to do something private to,
Thanks, Sal. So you definitely don't need to do anything private. That's the first thing. And I think you're right. There's often a bit of a misunderstanding. So on the side of the clinicians, that just because you haven't found a gene to explain the condition in the family, it doesn't mean that it's not genetic. Because we haven't discovered all the genes that cause these conditions, particularly for dilated cardiomyopathy. So in dilated cardiomyopathy, we only find a definite gene in about 30% of families, even when you know that it's running in the family. And as you say, in your own family, there are other people who have had heart conditions. So I think, your son should definitely be under follow-up, for sure. It is true that for many cases of dilated cardiomyopathy, it's less common for there to be very obvious signs in very young children, and it often is during the teenage years, or actually even beyond that, sort of early adult years, where you might start to see features. But that's not always the case. And so our own practice certainly is that we would offer ongoing screening, and it might be every 1 or 2 years at this sort of age, and then maybe a little bit more frequently as they get older. But it's really important that they do stay on the follow-up. And even if we haven't found a gene yet, that doesn't mean that we won't find one in the future. Also making sure that the whole family has been sort of properly seen, and all the right tests have been done, things like MRI scans and stuff like that, because that can sometimes help to narrow down the underlying cause. But yeah, I mean, I'm happy to have a chat with you afterwards if you want about sort of specific things. But yeah, I would definitely recommend he stays on the follow-up. Sorry.
Anyone else? Yes.
So my son has dilated cardiomyopathy, as I mentioned earlier, and he started on an ACE inhibitor. What evidence is there that it's beneficial at that? Because he doesn't have symptoms other than the enlarged heart. So how will that help?
So that's a great question. And so actually there's a lot of evidence for drugs like ACE inhibitors, and actually a whole 4 or 5 different classes of drugs that are useful for improving long-term outcomes, and in some cases they might prevent the heart from getting worse quickly over time. Most of that evidence doesn't come from dilated cardiomyopathy, actually. It comes from ischemic heart, it's a coronary artery disease, so further up coronary arteries leading to enlarged heart muscles. But there is some evidence, even in the cardiomyopathy group, that's the case. It's quite tricky because those drugs aren't used to treat symptoms. They're not going to make him feel any better, but they're there as a long-term drug to improve long-term outcomes and to prevent what we call adverse remodeling, so the heart getting progressively larger and the pumping function getting progressively worse over time. So yeah, there are good reasons for him to be on ACE inhibitors.
One final call for question. Yep.
Just want to say thank you for the panel today. Everything's been really insightful, and hearing personal stories as well and what the charity is doing now. So my family, my dad has it. I'm screened every year. I get my echo. I'm high risk because it's genetic. So it's quite passionate about it. But I work with a charity that works across with the age group you're talking about, between sort of 13 to about 21, but across conditions, so things like sickle cell. And I was just wondering, is there sort of a crossover, like you're saying, it wasn't easy to meet other people with the same condition, but is there sort of, is GOSH or the paediatric services, even in London, doing anything to bring that age group together? Is there sort of like an actual structured process? Because the work I'm doing, it changes hospital to trust, and it's quite difficult to find like a uniform process for that particular age group.
Yeah, so I guess there are sort of a few different things related to that. So one is what can be done at the level of sort of charities, peer support and things like that. I guess another question is what can be done at the level of individual services or centres. And so I know, for example, at GOSH, at the moment, we look after people up to the end of 18, and then from 18 we transition them generally to BARTS, which is the adult bit of our service. And we have transition clinics, so that it's not, as Emma said, a really sort of strong endpoint at one point. But we are actually working on hopefully convincing both trusts to set up a separate, so this is where my question was coming from before, to set up a separate clinical service, almost like a new service, so not an extension of one or the other, but actually a brand new thing. So once you reach a certain age, 14 for example, you move into this new service. There's always going to be some transition at some point somewhere, but it feels to me as though sort of 14 and 25 is better than 18, just because of everything else that's happening. So we're trying to sort of work on that, but I guess I asked the question because if that wasn't something that you would be interested in, then actually there's no point us doing it. But if it sounds like there would be some interest in that sort of thing. So, but obviously different places have different sort of ways of working. So what works in one centre may not be appropriate for somewhere else.